delighted to hand you over now to Professor Indi Banerjee and Helen Stokes for the session now. Thank you very much.
Thank you ever so much, Helen. Thanks for inviting us, and thanks to all our parents and families who've taken time on a Friday of all days to come and listen to us. So we're based in Manchester, where the sun unfortunately isn't really shining, never does. But we've been in the business for many years, and I'm a consultant, nearly 15 years, and Helen, our more than able specialist nurse, is here also to help us through. But I suppose the floor is open to you to discuss your queries and questions and comments. Are most welcome. I will start just to kind of get people to start thinking a little bit with a short presentation, but then interject, and I'm sure you will on the chat, so I'm more than happy to direct our discussions to your thoughts rather than mine. So without much ado, if you are happy, then I might share my screen. I'm hoping to bring up a short presentation on hypopituitarism, the kind of things that are important for us, but I'm sure you can tell me if I'm going off piece. So as I said, we work at the Children's Hospital, and Helen and Julie, who's not here, are our specialist nurses, and we have a really good team because this is quite a complex condition. Now, I might want to start with something quite simple, and we are all used to measuring and weighing children, and you might think it's a simple job, but this is Sue, who is one of our outpatient nurses measuring one of our children. This is a slide actually going back to 2007 or 8, which is quite a long time. And this is our older hospital. And what she's demonstrating is using a stadiometer. That height measurement is absolutely precise and accurate, and we need to plot that on a height chart, as you see here. And the height chart shows very clearly that the height is gradually drifting downwards. And we also tend to use on your right-hand side, you can see the mid-parental height. So your height is determined by parental heights, and we try and make an estimate of what your child's height is in relation to parents' heights. So measuring height might sound simple, but it is actually quite a complex thing. And this stadiometer, the reason I have this slide is that this stadiometer was actually thrown away, and Julie, who was part of our team, actually rescued these stadiometers when the hospital was moving to the new children's hospital. They were being thrown away, and these costs quite a lot. They're about £1,300 each, whereas the ones you can buy on Amazon are something like 50, 60 quid. Well, it is a really important part of what we do. And it's just helpful to understand that nutrition has a very important part in growth in the early phases of life, where growth hormone doesn't quite kick in, but then after, say, 2-3 years of age, you come to have this growth hormone dependent phase where children who have hypopituitarism, their growth starts to falter. So if the height is carrying, or should be on an upward trend, you often find that the growth is decelerating, slowing down at this sort of age. And come puberty, there is a bit of an upward trend again, not only growth, but also puberty kicks in at that stage. Just to show you what a normal pituitary looks like, because that's what we deal with day in, day out. So I tell my children and young people who want to look at their brain scans that right in the middle of the brain is this P-shaped gland, which is a front gray part and a back part, which is a little bit on the whiter side. and that's hanging by a pendulum or a thread, and that's the picture of the pituitary, and the part above that is slightly ill-defined. It's called the hypothalamus. It's quite helpful to know that because they're often asking questions: what's wrong with my pituitary? Do I need growth hormone for life? And do I need my hydrocortisone for life? Those sort of things. It's helpful to know what the pituitary looks like and what it actually does. So here on this slide, you can see that there are many, many functions that a tiny gland does. I don't need to tell you all of this. I'm sure you know more about me, but the ones that I've highlighted in the yellow and orange are the stress hormones, so the cortisol producing ACTH, and we call the water hormone, or AVP. I think those are the two things that always raise red flags in case they are going wrong. And just to make the point that there are conditions, we talk about hypopituitarism that may be from birth, and this is an example of that. You can see that the pituitary gland is quite shallow and flat, and the back part, which should have been here at the back, has gone right up there, and it's called an ectopic posterior pituitary, which means that the gland didn't develop so very nicely. And that's an example of a child with typical hypopituitarism. Now, you think of congenital hypopituitarism as the only child with, or sometimes adult with hypopituitarism, but there are other forms as well. And we sometimes get distracted by other things that tell us that growth is a little less than good. So this is a 10-year-old boy, and he presented with Crohn's disease. For those of you who don't know what Crohn's, it's a condition of inflammation. So this is looking down the food passage, and you can see it's kind of quite red and angry and full of ulcers, and that's the typical pattern of somebody's food passage when they have Crohn's disease. And this child who had Crohn's disease was falling off, gradually slowing down. However, his weight was starting to pick up, and we realized that in addition to Crohn's, while the child had treatment for Crohn's, his height wasn't improving. And you can see that even with Crohn's treatment, the child's height was not getting anywhere better. And when we realized that this child also has another pathology, and here is what is happening in the area of the pituitary, you have quite a large growth, and it's called a craniopharyngioma. It's a tumor in the pituitary, sometimes happens above the pituitary. In this case, it's just sitting within the pituitary gland. And this young man had a transsphenoidal, which means going up through the nose, surgery, and is extremely well, but obviously requiring replacement hormone. So, you know, hypopituitarism comes in various guises, can be from birth, can happen later on. The one thing that really makes us worry, and certainly Helen, and this is a lot of our time is spent on trying to prevent adrenal crises. And this is a young man who has Addison's disease, and not strictly hypopituitarism, but a lot of our children with hypopituitarism also have adrenal insufficiency, because we talked about the brain ACTH that drives the stress hormone from the adrenal glands, and that's not good enough. And it is important because people for a while used to think that children who have hypopituitarism don't go into adrenal crisis. It only happens to those with Addison's. So Addison's is where you have a problem in the adrenal gland. That's not really true, and it's really, really important that we get this right. And this is something that the British Society of Pediatric Endocrinology are also quite passionate about. For those of you who have seen the steroid card, you can download it from the website. The good thing is that although we talk about double or triple doses, actually you can modify, you can change the dose. So what your consultant has given you as a dose, but make sure that the sick day hydrocortisone is good and robust. But the most important thing is making sure that we can give emergency hydrocortisone at the time of extreme need. So if your child is really ill, don't hesitate, give him or her the injection, and that is going to be life-saving. So that's really, really so important. And we did some studies within our Northwest, and we actually found that parents do take up this education, but actually giving the hydrocortisone is sometimes a step too far when things are happening in a rush and everything is in a panic. It is not easy to give the hydrocortisone, and this is where I suppose Helen's expertise really, really comes in. And we're trying to diversify not just leaflets, but also different types of information. For instance, Helen can talk about her experience of producing a YouTube video that I'm sure she'll be more than welcome to share. But I thought at this stage I'll take a little bit of a pause and see what people have to say, and then bring in Helen. Helen, may I ask you to answer this? What do you think?
Yeah, so I mean, we will always speak to nursery staff, you know. I mean, we used to go in and, you know, do training with nursery and speak to them about, you know, what to look out for if your child does become unwell. But now, because of COVID, we've been doing it a lot over the phone, sending emails, sending information over emails. So, I mean, we would always speak to staff, you know, and just give them a brief understanding of the condition and, you know, why they're giving the medication. Because a lot of the time, you know, they're giving doses of medication and they just want to understand why they're giving it, really. So, you know, once we've gone over all of that, explained what to look out for, what to do if they do become unwell, I find that nurseries and schools tend to feel a lot more relaxed about things. So, yeah, we will always do teaching.
So you're absolutely right. Your son has a healthcare plan. And you discussed, I'm assuming a specialist nurse came into school to talk to teachers, and that this is what Helen used to do before COVID hit. I don't know, are you able to do that now that COVID is there everywhere?
Yeah, so I mean, the nurseries and schools normally do the care plans. We give the information to them, they'll do the care plans, and then we give them the option that they can email it over to us and we can read through it and just add any information. So, you know, a lot of the time a care plan's absolutely fine once we've spoken to them and they understand, you know, everything that's on there.
So that's very helpful. I just wonder whether, Helen, would you think demonstrating the use of intramuscular hydrocortisone might be helpful? I know it's, you know, people know about this and they've had information in several guises, but there's never, I think, this message to give intramuscular hydrocortisone is never wasted. So would you want to have a quick demonstration?
Hi everyone. So what I thought I'd do today is I thought I'd just go through just what you should have in your emergency kits and just go over drawing up the injection, really, just so that it's another bit of a refresher. So I'm going to angle the camera down just so you can see what I have got. If it works. There we go. So in your emergency kit, you might have different things depending on the age of your child. So some of our kits, you'll have a little 1 ml syringe, okay, and that tends to be for children that are on a smaller dose of the intramuscular hydrocortisone. Then you'll have a red filter needle and you'll have an orange needle to administer it. Other people in the kit might have a 2 ml syringe, which is a bigger one for older children. You'll have a red filter needle, and then you'll have a blue needle to administer it. So today I thought I'd go over giving the pre-made liquid vial of hydrocortisone, and I thought I'd also just demonstrate the powdered hydrocortisone, just because I know that sometimes, you know, we will always send you home or give a prescription for the pre-made one, but sometimes the GPs, you know, if they're struggling to get hold of the liquid one, they will give you the powdered one. So I thought we'd just go over that as well, just in case. So first off, okay, obviously your emergency injection is going to be for emergency situations. You know, if your child is vomiting, unable to tolerate their, you know, oral hydrocortisone, if, you know, they've had a serious accident, injury, or if ever they become unresponsive, unconscious, anything like that. Okay, so first off, your liquid hydrocortisone, what you need to do is you'll just need to give the top of the vial a tap, just so that any of the excess liquid just in the head drops to the bottom of the vial. Okay, then what you'll see, there's a blue dot. I don't know if you can see it on here, but there'll be a blue dot just on the top of the head of the vial there. Now what you need to do when you're snapping the glass vial is you need to put your thumb over that blue dot, your finger behind, and you need to snap away backwards. Okay, and what that should do is that should leave a clean break just round the vial. Now, what I tend to say to families is to use a tissue when you're doing that, just because if the vial snaps or it shatters, at least you've got a tissue around your fingers so you don't cut yourself. Okay, so exactly the same, put your thumb over that blue dot, your finger behind, and you're holding the vial, if you can see. And then all you want to do is just snap backwards like that, and it just leaves a clean break. Okay, so you pop that down. Then what you're going to do is you're going to get your syringe, okay, and you're going to open your syringe, take it out. Then what you're going to do is you're going to open your filter needle first and put that on your syringe. Now, we use a filter needle with glass vials, and that's just because when you snap that lid, you don't know if little bits of glass go in the medication. So we always want to filter it out beforehand, okay? So put your needle on the end of the syringe, and holding it away from you, pull that cap off, okay? And then you've got your needle, and it's quite a big needle, but just remember it's your filter one, okay? So then what you're going to do is you're going to get your vial, and you're going to put your needle just into your vial like that and draw up your medicine, okay? Just depending on the dose that your child is on, okay? So once you've drawn up your medicine, okay, and I always say just draw up a little bit extra to what you're going to give, okay, just because you will get air bubbles in the syringe, okay. So once you've done that, okay, you've filtered your medication, so you're going to take that needle off, okay, because you're done with that needle now, you've filtered your medicine. And then what you want to do is you want to put your orange one on, okay, because that's the one that you're going to give it with. So you're going to open it up, okay, and it just goes just on top like that, okay. Now what you'll see is you'll have an air bubble just at the bottom of the syringe, okay. So what you want to do is just tap it, okay, and sometimes you need to tap it quite firmly just to bring that bubble to the top, okay. Then once you've done that, you can push your plunger up, okay, so you get all the air out, okay. And then what you're going to do is you're just going to push that plunger up to the dose that you've been told that you would need to administer, okay. Once you've done that, okay, you're going to take the cap off, and you want to hold it away from you and just pull it off like that, okay. Then it's going to go into the muscle, okay. So what we do is on the side of the thigh, okay, you're going to pinch the side of the leg just to raise that muscle, okay. And then what you want to do is you want to go in at 90 degrees, and you're going to go straight in, okay, all the way, and then you push all the medicine in, take it out, and you're done, okay. And then your needles and your sharps and everything, what you'll do is you'll just put them in your little box that your kit was in, okay, and then you give all of that to the paramedics or to the hospital, and they will then dispose of everything, okay. So that's your pre-made one, okay. So what I'll do now is I will just go through how to do the powder, okay. So with your powder, okay, you're going to have your vial, which has got your powder in, and you'll also be given some water to mix it up with. So you're either going to have a glass vial of water, or you're just going to have a plastic bottle that's got your water in, okay. So what you're going to do, okay, is just pop the lid off. So the cap just pops off the top of the vial, okay. And then you can open your water. Either if it's a glass vial, you're going to do what I demonstrated before, putting your thumb over that blue dot and snapping backwards. But if it's just a plastic one, it just twists and snaps off. Okay. So once you've opened your vials, you can then open your syringe. Okay. So open your syringe and take that out. Okay. Then you're going to get your filter needle. Okay, now it might be that you might not have a filter needle, because if you've just got a plastic bottle, you don't need to use a filter needle. You could just draw it straight up with your blue needle. Okay, but if you've got a glass vial of water, then you'll need to draw it up with your filter needle. But don't worry, if you've got one and you just use it in a plastic vial, it doesn't matter. So I'll just do it with it. So put your needle on, okay, and pull your cap off away from you. So you're going to put your needle and syringe in the water, okay, and you need to draw up 2 mils, okay. So you draw up your 2 mils of water. If you draw up a little bit more, don't worry, okay. Then once you've drawn it up, take that needle off, okay, and then you're going to put your blue one on, okay, or your orange, depending what you have. Put your needle on, okay, making sure that you've just got 2 mils of water. If you need to push a little bit of excess water out, that's fine. If you've not got enough water, just do exactly the same. Just put your needle back in your vial of water and just draw up a bit more. Okay. So then once you've done that, you need to take your cap off. So just pull your cap off, okay, and then you need to mix your medication, okay. So it's quite a bit of powder, and that's why we just say 2 mils for this one, just because we want to make sure all that powder is mixed together, okay. So in the top of the vial, you're going to insert that needle like that, and then slowly you're going to push the water just into that vial, okay. You don't want to do it fast because it bubbles, okay, so you just want to do it slowly, okay. Once you've done that, okay, you can either pull your needle and syringe out and mix it, or if you feel confident, you just mix it all together, okay. So what you want to do is you just want to spin the vial slowly, just so it all mixes. You don't want to shake it vigorously, just because that's when it starts to bubble up. Okay, so once it's all dissolved and you can see that it's all dissolved, then what you want to do is you want to draw up your dose. Okay, so you'll either put your needle and syringe back in, okay, or if your needle and syringe is still in there, you just draw it up, the dose that you need. If you draw a little bit more up, don't worry, take it out, okay. And then what you're going to do is you're going to push your plunger up to the dose that you want to administer. Okay, and then exactly the same side of the leg. Okay, we want to get into that muscle, so you're going to pinch the side of the leg, so you're raising that muscle up, and you're going to go straight in 90 degrees all the way, push your medicine in, take it out, and you're done. Okay, and exactly the same, all your needles, your vials and everything like that, you will put in your little box that you had your kits in, and hand it to the paramedic or the the A&E department, wherever you go. Okay, so that is how to administer.
Helen, thanks very much. That was very helpful. You may want to just switch the camera so you don't just see the needles. See you as well. So whilst you are discussing a very important part, I've had a number of queries in the chat, and I'll kind of go through them one at a time. So the first one was congenital hypopituitarism, and what are the causes, what causes this, why is this there from birth? And sometimes there are genetic causes, so there are some genes that switch on and switch off certain things that help the pituitary gland develop. So the pituitary gland suddenly doesn't wake up one day. It happens in bits and pieces in early life, and there are some switches that tell the genetic codes. We are born of genetic codes, and genetic codes make things happen bit by bit. And those things are controlled by genetic code, so the information map, if you like, in your body, and some of them could go wrong. So that's one possibility. Sometimes we don't always find the cause, and sometimes it may be that when the baby was really small, the blood supply to the pituitary gland somehow got disrupted. So that may be a cause. So yes, there are genetic causes, and there are sometimes we just don't find any reason for it, and it may be to do with how the pregnancy was progressing, if something happened during pregnancy. So unfortunately, we can't always make a diagnosis. Okay. Second question from was around other pituitary hormone deficiencies. I think you were saying that you were initially told your child has isolated growth hormone deficiency, which is quite often the case. We find one problem, and the reason being the pituitary gland has a number of hormones, but the growth hormone by far is the biggest of the lot. And the first one to go, therefore, is growth hormone. And then things evolve, and it may be that as the child grows older, your child needs more of the other hormones, and then that's the point where the other hormones start becoming insufficient. So you may start with an isolated growth hormone deficiency. As time goes by, you may see other things becoming more obvious. And I'm sure you've had the experience, and you worry about the synactin test. The synactin tests for adrenal insufficiency. And it's great to know that your child's synactin was normal. Fingers crossed that may never happen, because the synactin, or the cortisol producing ACTH in the pituitary, is the most resistant, and hopefully, fingers crossed, everything will be fine, but it is worth checking. How do you check? I think if you're seeing tiredness and unusual lethargy, then it is worth checking the synactin test time to time. So that's responding to Andrea. Helen, there's one really important pertinent question around school staff. Some staff are not able to give hydrocortisone, and I kind of completely understand that. How many do you train? And, do you want to talk about what you talk about in school, about school staff administering IM?
Yeah, so in school, we'll always recommend that they have a kit. So school, nursery, childminder, anything like that. We'll always recommend that they have a kit. But what we don't do is we don't train them to administer it. So we don't train teachers or staff to give that, just because we don't have the resources to keep updating them, on the injection. And, it's a lot of responsibility for them to take. So we will just advise, that if they do need to ring 999, they've got the kit there to hand over to the paramedics, or alternatively, they're going to be ringing family members, and if family members arrive at the school or nursery first, then there's a kit there for you to administer the injection, and it can be done that way. But yeah, we don't tend to teach them how to give it.
Yeah, thanks, Helen. So also picked up the same point, and she was told when given the intramuscular hydrocortisone prescription, she was told to hand it to paramedics, and we were just saying maybe you should also learn to use it. It's never a substitute for the parent. I know it's a bit daunting, but it's always good to learn.
Yeah. Definitely with family, we will always train them and get them to practice, drawing it up and just giving it to a sponge. So definitely with family, we'll always encourage that. But with schools, we'd
the paramedics may take 10 minutes to come to you.
Yeah, that's it. And in that time, you could have drawn up and given it. If you are at home, but if you are at school, then it's just safer for school to wait for the paramedics to arrive and for them to assess the child and then decide on what to do.
So there was another question around adrenal crisis in small children, babies, and it is a really difficult one. I mean, how do how can you tell whether a little baby is showing signs of adrenal crisis? And I have to say it's not the easiest, but as a mum, you probably know that your child is not great, and it's more than you can tell more than a doctor can do, to be perfectly honest. But I would say, you know, if you're getting hypoglycemic, you often see signs of jittery, child not waking up, becoming sleepy. What do you think, Helen?
Yeah, so I normally just say, you know, pale, clammy, lethargic. You know, it might be that they've been unwell for a few days beforehand, you know, and all of a sudden you've noticed they've been on sick day or something like that. And then all of a sudden you notice that things are just getting a little bit worse. You know, they might be really tired, not waking up. You know, like you said, you know, Professor Banerjee, you just have that sort of, there's just something not right here. There's just, you know, it's that sort of instinct, isn't it?
Yeah, no, that's absolutely fine. I had a question that my son has no sense of smell either. Is that something that can be fixed? We're increasingly recognizing that children with hypopituitarism also have maybe a genetic change that can also affect the smell nerve. It's a difficult one because we've only started to understand this a bit more, so I can't guarantee it'll be fixed. But sometimes you see things changing and evolving. So I'll keep my fingers crossed, but I can't reassure you completely. But let's wait and see. I think if we have new evidence, new information, we can certainly share. Are there any advancements in making norditropin growth hormones or weekly injections instead of daily? So Helen, we know that we've been in part of a trial to use a longer acting. So yes, there is a plan. I can't tell you when that will come to the market, but that's something that's happening in trial, certainly in the UK and other places. Ask the question, my daughter suffers from extreme fatigue, and although her thyroid growth hormone hydrocortisone levels are normal according to doctors, and it's something that we often see in teenagers and adolescents, the fatigue, I do think we need to, when you say they're normal, they may need to be optimized a little further, but also don't doubt that, you know, this is a complex condition and it's playing on your child's mind as much as the body. And sometimes we often will seek clinical psychology opinion just to boost up your young person, just to say, look, everything is good. Let's try other techniques to get you back onto rails. So it's a really important thing. And I can only give you the optimism. This will pass. As long as you kind of keep things ticking along nicely, give him or her, or it's a she, the optimism to move forward. Says, I've had the kit for 4 years and never had to use it. Good to use refreshers. So Helen, kind of making your point, and Helen, I've also shared the My Cortisol app. Yeah.
So
I'm sure she.
Yeah, so we've got the link. I did a video of myself drawing it up exactly as I've just shown you now. So there is a YouTube link that I think is going to be shared after, so you can view that. There is the My Cortisol app as well, which is really good. So there's videos on there. The only difference is that was made by Great Ormond Street. So there are some differences. I don't know. I don't think they use a filter needle when drawing up. So there are differences, but it's good to have the app. You know, it's got some really useful things on there. So I would definitely recommend downloading, and it's free to get, you know, free to have on your phone. So I think they're both really good, you know, things to use.
It's a really important question. My son suffers from extreme fatigue and kind of makes the point about young people and tiredness and lethargy. I would say, you know, that your son is probably kind of going through understanding more of his condition, and it's really important to look at the fine tuning of his medicines as they are. I didn't ask whether your son has adrenal insufficiency, but it's worth getting that checked out again. Sometimes thyroid, they might look normal, but you may find that the level of your dose of levothyroxine may need to be adjusted upwards. So you just have to fine tune that bit. Again, at 17, if son has stopped taking growth hormone, whether we need to go back to adult use of growth hormone, which I'm sure we can, it's an important quality of life aspect, maybe not here for this meeting, but for another time, and certainly ask the adult experts. What does an adrenal crisis look like? Helen, do you want to answer that? How does an adrenal crisis look like? And what point do you administer the injection in older children?
So, I mean, for the older child, it's going to be, if they've had a serious accident, if they've, broken a bone, broken a leg, broken an arm, anything serious like that, concussion where you've knocked yourself out, if you're vomiting and you can't, tolerate your oral hydrocortisone. I mean, here we always say that if you're having sort of 2 large vomits in an hour and you can't keep that medicine down, we always just say give that injection of hydrocortisone and get the child to hospital, because it's just the safest option to do. So, I mean, it's going to be any situations like that. If they're pale, clammy, they become unconscious, unresponsive, anything like that, you just want to give them that injection of hydrocortisone and just get them to hospital.
Okay, thanks, Helen. So has made a kind of a slightly worrying, heartfelt plea about, is there a main point of contact for us parents for an in-depth diagnosis? And she makes the point that she actually fought for the diagnosis, and I completely sympathize with you, Lisa, that some doctors and maybe, I don't know, local practices may not recognize hypopituitarism. So as you describe it, diabetes insipidus, which is the water form of diabetes, and you pass too much water. He was first diagnosed at the age of 5 years, and then it took a couple of years for the penny to drop in that. Hypopituitarism was diagnosed later on, and that's an important thing about watching carefully. And we would, if we were with us, we would say it is an evolving thing, and sometimes you may not see everything all in one go. The celiac disease, I have to say, is probably incidental. But as I was saying in my presentation, sometimes 2 things can coexist. So you have to keep a broad mind. I think I get a lot of queries from the Pituitary Foundation, so from Sean and Pat McBride, that a lot of families have to fight for their families and their children, which I have to say that should feel a little bit more easy. And I think something that the foundation may want to help families with. I don't know what's the best way out, and I might ask Sean at the end of the meeting how you can facilitate people like Lisa who've been struggling against the medical establishment, if I might say so, to get their voices heard. So it is a really important point. Dell Studio says benefits of taking growth hormone in adult life is exactly this, that we make growth hormone. Helen makes growth hormone, and Helen's already very, very tall. She doesn't need to grow any further. But we need growth hormone because there are other body functions. Our cells are kind of turning around, so they are under growth hormone. Our bones need a bit of growth hormone to help along, and we need growth hormone to keep our muscles strong. So there are quite good uses of growth hormone. Yes, we do need to produce a little bit of growth hormone even in adult life, although we're not growing. I wish we did, but we don't. And then I'm in the process of applying for school nursery. I have to provide evidence from a medical practitioner, paid letter from the endocrine pediatrician. Local council not helping. Helen, would you?
I mean, I don't know whether you'd be able to send like a clinic letter. I don't know whether that'd work. I've not come across anything like that before.
We
So
often
yeah, I don't know whether a clinic letter or contact your, you know, endocrine nurse or endocrine doctor and just see if they can, I don't know.
Well, can I suggest to families that you have a general letter anyway describing your condition, which you can cycle in different places. So have a letter in hand saying, you know, your son or your daughter has a condition which is this, your child needs this, and it's not a bad thing to have in hand. Paper copies often get mislaid and get damaged over time. So I might suggest that when you have the letter, ask for a PDF version from the secretaries, or if you can't, then just take a photo and store it somewhere on your phone.
So we provide letters like that, but also actually on the app, on the My Cortisol app, there is a doctor's section, and on that section it does list. I mean, it doesn't list specifically for certain conditions, but it does give a generic rundown of what to do if your child was ever taken to hospital, you know, i.e. fluids, investigations, things like that. So that's quite handy as well.
So Helen, there is another point asking about disability living allowance, which some children may be eligible, particularly if they have other concomitant disabilities. I just wonder what you would have to say, Helen.
Yeah, so I always say it's definitely worth applying and, you know, trying. I mean, there is a section for healthcare professionals to fill in, and we'll always fill that in for you and put our details down. I mean, sometimes it can be hit and miss with them, you know, whether you do get the DLA, but I always say, you know, if you've got the time to go through that application, I always say it's definitely worth, you know, applying, and we're more than happy to help send information or supporting, you know, information to help that process.
Except Helen, JRG says that endo nurse won't help, which is
well, they should, because on the DLA form, on the actual form, there is a page where the professionals do need to fill it in, so they should be able to do that. It's just what, I can't remember which part it is, but it's just one page where you write a paragraph and your details, how often they're seen, and, you know, when they were last seen, and so they should be able to do it, should be able to fill it in.
I suppose some people might say that it is just only giving growth hormone and it doesn't really impact on life, but as families, you do this every day, and mind you, you're doing this not just for, you know, a month, you're doing this day in, day out for, you know, a good part of 10, 12 years. And it's an easy thing for DLA to turn around and say it's just trivial. I really don't think so, particularly if you have other things. If you have hydrocortisone, you have to constantly watch over your children. Now, I appreciate that this may not attract DLA at the highest level, but I think as parents and families, you do have to spend a lot of time. Every single waking minute is spent thinking about what if something happens. So I completely take your point about that. And then Del Stew says, my son's growth hormone was stopped. Is this something we should push to continue? I was thinking of the possible consequences of not continuing with it. It needs a discussion, I have to say. And not every child benefits from growth hormone as an adult, but there are things that we should be discussing. Quality of life is certainly one of those really important things. In the past, we used to have a questionnaire called an AGDA questionnaire, which is basically a quality of life. But the questions were relatively simple, and, you know, they're not truly reflective of the true nature of quality of life. And having said that, it's a starting point. We also look at bone density. So we will scan a child becoming a young adult, their bone strength. We can do that on a bone density scan. And we'll also measure their blood fat levels, so lipid levels, is something that we would do. So it's kind of a composite assessment to find out if they were really, really low and if they might benefit from carrying on with growth hormone even as a young adult. So absolutely worth a discussion. Is when child or babies unwell on sick hydrocortisone, should I expect they overcome the virus and bugs fine? Yes, I would actually. So I would, children are quite resilient, and I would expect them to overcome, again, within a couple of days' time. The one thing I would say, our experience with COVID-19 and something that we've worried about in the early phase of the pandemic are our children with hypopituitarism or adrenal insufficiency, are they going to be more likely to come to harm? And the answer is, thankfully, no. I think children are very resilient, and our kids with adrenal insufficiency haven't gone into adrenal crisis or been really unwell. So yes, I would expect them to ride over even horrible things like COVID-19, fingers crossed.
Indi, could I just interrupt for a second? That I've had a private message through that's not on the chat. If I could read it, is that okay? Okay, so my son has ectopic pituitary and is taking growth hormone and thyroid replacement, but his ACTH levels have always been okay when checked. Are we just lucky, or is he likely to have cortisol issues as he grows?
So this is coming back to the point whether things evolve, and I think I wouldn't say lucky is the right answer. Most children who have congenital hypopituitarism don't always have cortisol deficiency. That's the last thing to go. So I'm going to keep my fingers crossed for you to say that this will never happen, but it's always good to be on your guard. And so I wouldn't give you full reassurance, but I'll keep my fingers crossed for you. Okay. If I come back to a few other things, do you think hypopituitary affects circulation? My daughter, 3 years old, has got cold hands and feet, especially when unwell. It's a little difficult because every child is different, and I get hands that are cold and blue if the weather is cold. So it's not always the case, but I'm assuming that your daughter's synaptin test, the adrenal, has been tested, and importantly the thyroid. So those are the two important things. Just bear in mind. If you have any doubt, discuss with your doctor. Okay, and again, Gerard, you said your son's hands and feet can be an issue. I take your point in terms of the other effects, but if you're treated, you should be fine. Is there a genetic link with pituitary issues? There are genetic changes that can happen. My son has ectopic posterior pituitary and hypopituitarism. Mine was checked later in life, and I have the same, but only have hypopituitarism. Okay, my brother has a child with growth hormone deficiency. It's not as straightforward as that. There are genetic causes we don't quite understand. There's something called dominant, which means you pass on the tendency in a 1 in 2 to your children. So there are different forms of growth hormone deficiency, which are what's called dominantly inherited. So you can pass it on, but not all of them. So that's why it gets a little bit tricky, but it's worth exploring that with your endocrinologist. That's a really important point about emotional psychological support. And this is where Helen is quite good at reaching out to families, even if they're not discussing hardcore medical things. It's often family support is really, really important. A really important thing about, could you talk about commencement of puberty and how can this be monitored? So you're right. We talk about puberty being another puberty hormones. By this I mean two particular hormones called LH and FSH, and they are really important in helping puberty move along. They're made in the pituitary gland. There is another hormone called GnRH, it's called gonadotropin releasing hormone, which drives the puberty hormones, and the GnRH is made in the place above the pituitary gland. So they're really important things to help you along. If you're deficient in one or both, then you might need help and support. And what I would say is, when you're coming to secondary school and your child isn't starting to show signs of puberty, and this by I mean that, you know, girls are different, boys are different, so you'll have to discuss with your doctors. But it is worth discussing this. Does your child need a little bit of support? And then the diagnosis of puberty hormone deficiency or gonadotrophin deficiency may also need to be considered. So if your child isn't producing puberty hormones, we need to supplement in boys testosterone, in girls estrogen, and that's a discussion we'll have to have, because if you don't do that, we talked about bone strength, and it's really important that we get bone strength through puberty. Also important that growth will be so much better when you start replacing the puberty hormones. Okay, so moving on from puberty, let me just see. What can we do to get GPs to realize every child will have a growth spurt? I was fobbed off by the GP for 7 years. My son was on a growth chart and that was fine. He was diagnosed with growth hormone deficiency at 12.5 years of age. That's a good point. I suppose I'll throw that back to Sean and ask the question from Pituitary Foundation whether we do a little bit of teaching and training to our local patch, but it may be something to promote more widely nationally. Sean, I might come back to you on that one.
Yeah, of course. And I think we are, I mean, behind the scenes, we do work directly with Society for Endocrinology and BSPED as well to kind of raise the profile of this and do kind of policy work in the background to make sure that the same information is spread through GPs to avoid this problem. And I think the more people that are aware of our foundation, that will stop this happening, hopefully. But it's kind of a group effort to get the word spread around there. But I think we have a lot of publications on our website directed at GPs as well for this reason. So we can always pass, we've got a GP like a handbook, and we can pass this to people to pass on to their GPs so that this can be avoided in the future.
Okay, well, thanks, Sean. There was an email about oxytocin, and I do recognize that question about oxytocin used in several children with emotions and hypothalamic obesity. This is part of a drug study, and the results are not completely disclosed yet. So I think we'll have to watch this. We don't usually give oxytocin. So oxytocin is another hormone made in the pituitary gland. It's the same hormone that when you have labor, oxytocin contracts the uterus, the womb. But some people think it doesn't have any real effects, but oxytocin has been used in trials because it probably has other types of effects which we were not aware in the past. So I'm waiting to see, you make a very important point about emotions and hypothalamic obesity. So watch this space is all I can say. Right, what else? The different types of cells in the pituitary may happen at different stages, and it's 9 years old, so it's not quite the time to show signs of puberty. So I'll probably wait till she's about maybe 10, 11. That's where most children start to show signs of puberty. So watch and see what that happens. It may or may not be the case that your child has puberty hormone deficiency, but it is important to watch that maybe next year or so. You asked the question, how will this be monitored, and do you expect her sex hormones to be tested? So clinical signs, and the pediatricians might show you or teach you how to look for breast budding. That's the first sign for girls, and I'm sure that when they do blood tests, they will also check for the levels of the puberty hormones and measure estrogen, but that will come later on. There's no point in doing it right now. Similarly, we are aware of ACTH deficiency. You make the point that you had a couple of short synactin tests. Synactin is the adrenal hormone test, which were normal, which is great news. I hope nothing comes to happen with the adrenal side, but symptoms are also important. If you see that getting unusually tired when she shouldn't really be, then it's worth asking the endocrinologist the question. And I think the oxytocin was, again, one of the other questions, Sean. Dell Studio says, could I just thank you for Pituitary Foundation? Absolutely, I do think it is such an important thing for families to get around, and I do appreciate that sometimes hypopituitarism, growth hormone deficiency, and other hormone deficiencies, because they are subtle, they are sometimes, certainly in my opinion, gets missed. And I'm sure that you've been worried throughout the COVID-19 pandemic. Our experience is that some of these issues have been put aside because obviously COVID-19 is the burning concern at the moment. But children with genuine adrenal insufficiency have been missed or put off, or not thought important. I also had problems where a lot of our GPs are doing consultations over the phone or over a video call, and things might get missed, which is kind of sad. But I'm hoping that the Pituitary Foundation will make a case that these will need to be addressed, and they are equally important. Okay, if I could just come back to, says my son has micropenis, which is just describing that the penile genitalia is a little bit small. He wasn't treated with testosterone. We started growth hormone. It helped those growths there, which is great. There is still time to improve the situation. He's 10 years old, it's not near puberty. I am keeping my fingers crossed, because with puberty, you will see some change, okay? And if he needs a little bit of testosterone, that will hopefully grow and change. So there is plenty of time for you, absolutely. My son is deficient in all hormones, but he has started puberty on his own, which is great news. It is unusual for all the other hormones to be deficient, puberty to have not been affected, but everything happens, so it is entirely possible. Okay, we'll stop there if there are any other questions from other people.
Brilliant. I think that's a good place for us to wrap up there. So thank you so much for everyone for all your questions, and sharing your worries, and by doing that you've helped other people by getting questions, so that's getting answers, so that's really great. And thank you so much to both Helen and Professor Banerjee for their time this morning and answering all of your questions and giving some really valuable information to take away with you.